Well, thank you, David, for that very kind introduction, and thank you to the Stambaugh family for endowing this lectureship, and thank you all for coming today. I'm very grateful. I'm going to talk about, as David mentioned, my book, When Doctors Become Patients, that came out not long ago. And I thought I'd tell a little bit first about why I wrote this book and how I came to write it and what I think some of the lessons are from the book. And on 9/11, my sister died. She worked in the World Trade Center and for one of the top floors. And for the first 2 weeks after that, I emptied her apartment, and we held a memorial service that I helped organize. We had to clean out her apartment, and she was in her 30s. She had no will. We had to figure out her estate. And I did all of that, and then my body just gave out. And for 2 weeks, I couldn't get out of bed. I lay in bed, and I didn't feel like watching TV. I didn't feel like reading. I didn't feel like listening to music. I just felt just staying in the nice, cool sheets of my bed are what felt best. And I thought I had the flu. And after it was on for a week, 2 weeks, and then a friend of mine who's a psychiatrist said, "You know, I think you're depressed." I said, No, I just have the flu." "No, I think you're depressed. I mean, you don't feel like doing anything. If you had the flu, you'd at least want to watch TV." Well, finally I realized, yes, I guess I'm depressed. So I went to psychotherapy, and first I went to, I'm Jewish, I went to a temple, then I went to a church, then I went to a Buddhist temple where we went around and rang bells and walked in a circle. And for the first time in my life, I spent hours doing nothing. I just didn't feel like doing anything. And finally I realized, yes, I was depressed, and got treatment and got better. But a few things struck me. One is I had trained as a psychiatrist, and yet I felt ashamed that I was depressed. I failed to realize that I was depressed, and I didn't realize this is depression. It felt much more bodily. It felt much more just my body just hurt to do anything. If I get out of bed, my body ached. And of course, we as physicians often have patients who come in and say, "Well, my body aches." Right? And we do tests and there's nothing wrong. And we often look down at the patient, right? Well, can't the patient just say he or she is depressed, right? But we think of sort of the physical expression of a mental phenomenon as being somehow the patient not being psychologically minded. And I was surprised that I had failed to realize this, and also felt shame. And I thought, well, if I am, as a psychiatrist, feel ashamed about feeling depressed, what must it be like for my patients? Right, and all of our patients who may be feeling these symptoms to voice this, etc. So based on this, I wondered, well, what do other physicians do with this? So I looked in the literature, and as I'd been taught to do as a good physician researcher, and there had been single patient accounts of physicians who became patients. So there was an account, you know, I was a neurologist and I got disease X, and this is my experience. And there had been 2 books that were basically compilations of, you know, a few different physicians, each talking about their experience. But no one had ever sort of tried to look across the board at how does this change the way physicians interact with patients? Does it change how they feel or look at what they do as a physician? What is it like to have power and then lose it? What do they now learn that they didn't know before? Why do some learn it better than others? Do some do less well than others? Do they change in different kinds of ways? And of course, there was also a film that was done about 10-15 years ago called The Doctor, with William Hurt, that some of you may have seen, in which this mean sort of son of a bitch, or mean, nasty, male chauvinistic surgeon, you know, nasty guy becomes a patient and becomes this loving, wonderful guy. And it's sort of the Hollywood version, right, of sort of from evil to good. And so I realized that's the Hollywood version. Who knows what the reality is? So I set out and I interviewed 75 physicians who became patients with serious illnesses, and tried to just look across the board at what their experiences can tell the rest of us, and that's what the book is about. And I was constantly surprised at what they said. So one of the first physicians I interviewed was a young woman who had breast cancer. And she said, "You know, I always used to think I was miscompassionate. I mean, I took good care of my patients. They were really important to me. I valued them." She said, "And then I became a patient. And," she said, "my eyes were completely opened. I had no idea what it was like to be on the other side." And that became a theme as I went through and spoke to these patients again and again, the kinds of things that they didn't know that they now learned and things that they unlearned as well. So to give you some examples, and some of the themes were in the book are about, on the one hand, becoming a patient. Some are about being a patient, right, sort of entering the sick role, so to speak, from having been in the doctor role, then being a patient, and then being a physician again, right, on the other side, and then treating your patients. So I thought I'd sort of go through these, as it were. And a lot of doctors resisted becoming patients, right? They said, you know, I felt like as a physician, I felt like I wore a magic white coat, I realize in retrospect, that this magic white coat would protect me, and there's disease, and it's over there, and I'm over here, right? And it's us and them. And some of these doctors said, you know, it was a step down to become a patient. You know, and constantly this theme also came out, how it was, you know, here's the doctor, there's the patient. So not only is medicine organized hierarchically in terms of here's the attending, there's the fellow, the resident, the intern, the medical student, but here's the patient, right? So it really cuts through it, and yet we don't look at how we use that power, or maybe at times abuse that power over patients. And these doctors now felt here's a window of opportunity for examining that. And how they relate to that, which they then did. And even in self-doctoring is something that came out, of course, throughout. And if you look in the literature in self-doctoring, we hear this term, you realize that it's much more complicated than it's usually described. So what became apparent is that there's self-diagnosing, there's self-medicating and self-treating, and there's self-prognosticating. And usually we think of self-doctoring, we think of self-medicating. But in fact, even earlier on, a lot of these doctors, in diagnosing themselves, didn't look at themselves as if they were patients. So these doctors would say, you know, one doctor said, you know, I was driving down the highway going home and I felt some pain. It was in my shoulder and went to my back, and I was wondering, well, could it be chest pain? Well, I don't have this symptom, I don't have that. So I pulled in my driveway and I went to my medical school textbook, and I pulled out the textbook, looked at comparisons, and I looked, and oh yes, the chest pain can in fact present in, you know, in the back. And so I got back in my car and drove to the emergency room. And you know, they sort of had a hard time sort of seeing themselves as if they were another. And how hard it is to integrate this with yourself. And in self-medicating, a number of these doctors said things like, you know, well, they would self-medicate in various ways. They would start treatments, stop treatments, increase doses on their own, et cetera. And for instance, one doctor said, you know, when I went in for surgery, because I needed surgery, I took a little, my own pain meds with me. I put them in a little sandwich baggie, and this way I had them at my bed, and I wouldn't have to bother the nurses. And again, people rationalize this behavior in various ways. And I should say that a number of issues came out about self-treating your family members, right? So a number of people said, you know, in the course of this, they'd say, well, you know, I also, of course, treat all my family. So my daughters, I tell them, yes, you need to go to the doctor. Or, no, you don't need to go to the doctor for that. And I think I didn't focus on that in the book, but there's a whole, as all of us are aware and should be aware, a whole set of issues around treating your own family and what we decide to treat. No, I'll just give you the antibiotic, or you do need to go, don't need to go, et cetera, in ways that is problematic, of course. And even these doctors resisted awareness of this in some ways. So one doctor said, for instance, well, you know, there's the guy who writes my scripts for me. I say, oh, is that your doctor? No, he's just the guy who writes my scripts for me. I write prescriptions for him, and he writes prescriptions for me. Well, is that your doctor? No, I don't really have a doctor. I mean, I sort of go to this guy for this, and I'll talk to that, and I have a buddy who's in, and people get curbside consults, et cetera. So we as physicians don't take good care of ourselves, and very often. And a lot of physicians, as I'll get to, would say, many of us are workaholics, and this became apparent too, and some of these doctors would say things, you know, I was getting sicker and sicker. But I said, you know, if I'm super doc, if I take care of more and more patients and do help more and more other people, I won't get sick myself. I won't die. And so there's a lot of magical thinking that also becomes apparent that usually we don't think of ourselves as engaging in, but of course we know patients engage in magical thinking when they become ill, and of course physicians, you know, not surprisingly, do as well. And these doctors realized all kinds of things that they didn't know before in terms of once they were patients. So one woman who was a gastroenterologist, for instance, who I described in the book, says, you know, I was sitting and I began to get some pain on my left side, and it got worse and worse. And in retrospect, she said my spleen was expanding. But she said at the time, it just got worse. I got in a cab. I had tickets to go to the symphony, and I had to get out of the cab. It got unbelievable. She said, the intensity of the pain. And she said, you know, I've been treating abdominal pain for 20 years, and I never had any idea that this is what my patients complained of, that it was so much more horrific than I ever would have imagined, than I ever could have put into words. And she now responds much differently to pain that her patients complain of, whereas before, okay, you have pain, you know, what are your LFTs, what does the chest x-ray show, or whatever, right? So she said, I had no idea that this is what patients were talking about. And the same with other sort of non-specific symptoms. So a lot of these doctors said things like, you know, fatigue. You know, they said, you know, patients complain of fatigue, okay, you know, but, you know, what are your LFTs, and et cetera, et cetera. But then I felt fatigue. They would say, you know, I couldn't do anything, and it was so horrible. She said, I never realized how horrible these sort of, you know, clinically non-specific, you know, symptoms are. Same with nausea, have ongoing nausea. You know, you know, we have nausea, you know, we don't pay much attention to it. We give the patient something for nausea, and yet patients with these doctors would say, you know, when I had nausea, it would go on, and it just completely took over my life in a way that I had no idea before. A lot of these doctors talked about the physical plant of how, you know, there were never any fresh flowers, a few of these doctors said. And so one of these doctors said, now in my clinic, ever since then, I bring fresh flowers in all the time. I work in a large hospital in the city, and interview doctors from other large hospitals, and they would say there was a crack in the window, and there was a towel kind of rolled up and stuffed in the crack, and the wind would come howling at night, and how horrible. And of course, as a patient, as a doctor, I'd been in many, many rooms like that with a crack in the window and the towel rolled up, shoved in the crack, and I never thought anything about it, right? I never thought, what is this like for a patient to have to sit there thinking their life is on the line, and the world is just falling apart around them as it is, and this is the case. And yet how blind we are as physicians often to the things that in fact impact quite greatly on a patient's experience. Now you could say, well, it's just the patient's experience, or does it matter? And yet these patients realize how important, these doctors realize how important these things are, partly because of their symbolic value in terms of the loss of dignity they represent, but in other profound ways too, and how existentially how profound that is. Similarly with communication, these doctors said that they, for the first time, became aware of problems. So I feel like I'm going in and out. Is that, you can hear me okay? This mic, so I should stand away from it. Yes, is that better? Okay. So one of these doctors I interviewed was a surgeon, for instance, and he said he'd been a surgeon for 40 years, elderly guy, and he said, you know, the night before I went in was going to have my surgery done on me, I was now going to need surgery, my surgeon said to me, you know, there's a 5% chance you may die tomorrow in the OR. And the surgeon said to me, you know, that night I couldn't sleep at all. And it's only later I realized that the surgeon could have said to me instead, you know, there's a 95% chance everything will go fine tomorrow. And the surgeon said to me, you know, I've been a surgeon for 40 years. I never realized that those two bits of information, which mathematically are the same, right? 5% chance you may die, 95% chance things will go okay, have such completely different emotional valences if you are the patient hearing them. And I never realized that. And now, of course, what I tell my patients and tell my fellows to tell their patients, et cetera, is much different. Similarly, there's lots of themes that came out around all these issues. Around communication, for instance, remember these docs said, you know, I'd be laying in bed and the doctor would come by on rounds and stand in the door of my room and say, everything okay? And I'd go, yeah. And he'd go on. And then I'd think, wait a second, why am I saying everything's okay? Everything's not okay. I don't feel well, this is wrong, that's wrong, I'm nauseous, etc. And yet they would tell me, I realize I want to please my doctor. that when I say everything's well, he's happy and he's my buddy. And if I say, well, this is wrong and that's wrong, he starts to twitter his fingers and gets anxious, and I sort of lost. And these doctors said to me, well, if I'm busy trying to please my doctors and it's blocking the information that I tell my doctor, then therefore all my patients, or many of my patients, must be trying to please me, right? And telling me things because they think it's what I want to hear, rather than telling me the whole truth. And yet they would say, you know, I never realized that my patients must be trying to please me, and that I'm giving off signals that encourage them to do that, and that I might be losing out on information that I hear as a result. Similarly, a lot of these doctors said, you know, when I left the hospital, the nurses said to me, you know, you were a good patient. You never complained. And some of these doctors said, you know, I thought about that afterwards. You know, that's the definition of a good patient. You don't complain. And I think that is sort of, for a lot of people in health, that's the working definition of a good patient, right? Well, clearly that's not good. So what should be the definition of a good patient? And I think that's something we don't really take into account. I mean, a good patient, to the degree that we think about it in a real way, is probably a patient who adheres to what we say, right? They follow everything that we want them to say. Well, that too may not always be the definition of a good patient, and certainly it's not necessarily a fair definition of a good patient. And again, I think these are things that we need to think about, because we have these assumptions. We use the term a good patient. Is he a good patient, not a good patient? We don't always think what it means. Similarly, around time, a lot of issues came up about time. So a number of these doctors said things like, you know, I went to see my doctor, and you know, he kept me waiting in the waiting room for 40 minutes. I couldn't believe it. I was sitting there for 40 minutes. I was climbing the walls. So I'd say, well, have you kept patients? Do you keep patients waiting? Well, I guess so. I don't know. I never really thought about it. I don't even know. And you know, what does that say, of course, right? And so some of these doctors said, you know, so whenever I see a patient now and I sense they've been waiting, or they usually are waiting, I'll say, oh, I'm sorry to have kept you waiting. And it immediately sort of melts a certain amount of tension in the room that I never really knew was there before until I said that. Similarly around time. So in talking about time, a number of these doctors said, well, you know, my doctor said to me, well, your cancer shouldn't come back too soon. Well, what's too soon? Right? Or, well, you should have a while. Well, what's a while? Right? And we use these terms in medicine, or not just medicine, right? But time is such a subjective phenomenon, right? It's relative, right? The physicists tell us. And yet we give very little attention to how we talk about time. And yet what we think of as soon, or not too soon, may be quite different than what our patients do, in ways that I think we need to sort of think about more. Many of us do. And similarly, getting results, you know, these doctors would say, you know, I called for my lab result, and they said, well, it's Friday afternoon, you'll have to wait till Monday. And then I thought, why do I have to wait till Monday? The lab result is sitting on someone's desk. It's sitting in someone's, you know, computer. And now they'll say, you know, I make a point to make sure patients get lab results as soon as I have them, rather than, you know, they'll sit on my desk, I'll call the patient later, I'll call the patient Monday, tomorrow, whatever. And yet, waiting time, you know, some of these doctors, I never realized that to wait is to suffer. And in fact, in Latin, the word patience comes from, you know, time and suffering, right, are both embodied in our term patience. To have patience and to be a patient. Similarly, loss of dignity. So these doctors would say, you know, to sit there in a little gown with my butt hanging out was just horrible. A number of these doctors, though, said, you know, so now when I go to the hospital as a patient, I wear my hospital scrubs. You know, I wear my scrubs rather than a patient gown, which of course has several meanings. So some of these doctors said, you know, a few of these doctors said, you know, when I get chemotherapy, I'll prep the stuff myself. I'll do as much as I can so I don't need to have the nurses involved, you know, et cetera. And even things, these doctors interviewed a number of the women had breast cancer and had chemotherapy or other kinds of cancer for which they needed chemo and lost their hair. And they would say sort of the loss of hair had such a more disturbing meaning to me than I ever would have thought. You know, I had a red braid, and that was me, and now I've lost it. And, you know, patients complain of that, and, you know, buy a wig. kind of don't really think about it. And yet to be a patient suddenly and to have that loss, I would just feel like I've lost myself. And we don't realize what that means. If you look at even patient satisfaction surveys, how do you capture loss of self, loss of dignity? It's something that we really don't look at in outcome measures, and I think it's a challenge to think about how to do that, and that's something maybe we can talk about during the questions and answers. Similarly, talking about certain taboos, so psychiatric problems. So a few of these doctors said, I'd go to my doctor and she'd say, how are things going? I'd say, not so great. And they would tell me, finally it took 6 months and 6 visits for me to actually say to my doctor, actually I'm depressed and I think I'm depressed and I need treatment. And this, I felt ashamed to talk about, these doctors would tell me, feeling depressed or feeling anxious, that this was somehow taboo. And similarly, sexual side effects from medications. A few of these doctors said, my doctor would say, how you doing? I'd say, my sex life's not so great, And finally, it took 6 months for me to say, actually, I'm impotent on this new medication, and maybe we should address that medically. And that, of course, being another sort of taboo. Other areas, interestingly, had a comment on other doctors' errors. These doctors sort of felt now that they sort of had an opportunity to be on the other side. They were much more open in reflecting on a lot of their experiences. So they would say, how there's no check. If we see another doctor making an error, we say nothing. So some of these doctors would say, the nurses sometimes come to me and say, can you say something to Dr. Smith? I mean, his patient down the hall, Mrs. X, she really should be going home. And these doctors said to me, what am I supposed to say? So if I say to Dr. Smith, shouldn't Mrs. X be going home? They'll say, well, what are you telling me this for? You're not, I know her. I've known her for 10 years. You don't know her. What are you telling me this for, right? So there's no opportunity for feedback or commenting on errors. Even getting second opinions. A lot of some of these doctors would tell me things like, I decided to get a second opinion. Well, my doctor had a hissy fit, as if I was, going out with him and cheated on him by going to see someone else. And so even though we allow second opinions for certain things, in some ways there was a sense that it's sort of taboo, that it's sort of seen as implicitly as challenging a physician's authority. And of course we'll say, well, that's not me, I would never do that. But of course this is what happens, and this is, a lot of these physicians said they felt very uncomfortable often getting a second opinion, and felt this sort of, sense that this was somehow seen as criticism of what their doctor was advocating. Not always, but it was often there. A large area were spiritual issues that came up, and I hadn't anticipated this, but a number of doctors repeatedly said things like, patients used to ask me, they'd say to me, Doc, would you pray for me? And I'd say, yeah, whatever, and I'd kind of poo-poo it. And then I became a patient, they would tell me, and I suddenly realized how important that was. And I had never realized that that's important. No one in med school ever talked to me about it, and I was stunned. So some of these doctors said they became more spiritual in various ways. They certainly became more aware of how important that was when a patient's lying there, and would try to address it with patients to, saying things like spirituality is important to some people, or maybe it is to you, I don't know, but if you want to talk about that, we can talk about that, or I can have someone else talk to you about that. But they then began to address this in ways that they hadn't before. Right now, you can hear me now, but AV, I'm okay? I'll just keep talking. Everyone can hear me? Okay. At the same time, some would say, I realized, so I thought this is interesting, so I went and decided to look into the topic of religion and spirituality in medicine, and looked at the literature. And most of the literature is quantitative, and there's a book called Measuring Religiosity. So I got the book, and I looked at the book Measuring Religiosity. And as I began to think about what these doctors would tell me, and they didn't fit into the book. So, for instance, some doctors would say, well, I'm not at all religious, I'm not at all spiritual, but I believe that there is a truth that I seek to better my patients, to better everyone, to better humanity, and this to me is above all else. Now to me this was an incredibly spiritual person, but on any scale of religiosity they would be close to zero. Are you religious? No. Spiritual? No, etc., etc. So again, how we define these things is quite complicated. So some were religious or spiritual despite themselves. Some, I would call them spiritual or religious, even though they might not call themselves that. Or, I mean, one woman was a Hasidic Jew, a woman with metastatic breast cancer, physician. And she said that when she was in the hospital, the members of the Hasidic community came and visited her. And she said, I don't believe any of this crap. She used the word crap. I don't believe any of this crap. She said, but we just ask you to do one thing, they said to her, which is when you get home, just light Friday night candles, Sabbath candles. She said, so every week since I've gotten home, I light Sabbath candles, but I don't believe any of this crap. Right? So clearly this at some level had meaning to her, right? Even though she didn't acknowledge it. But again, these physicians had no way to really think about their approach to spiritual medicine was a very ad hoc thing. Some said, I wish I could believe in something. I see it helps my patients. I just can't bring myself to do it. And again, this is sort of a taboo area. I understand there's some movement here to have more attention to spirituality in the curriculum, and I think that's unique. Most medical schools, a lot of medical schools, give it no attention. I think it's something that we as healthcare providers need to think about in some way, because I think many of our patients are thinking about it in some way. Similarly, the sort of us and them, the hierarchy. So after being a patient, some of these physicians said, well, I decided I'm going to get away with the hierarchy. No more us and them. And I realized it doesn't work. And some of these were very politically active, people on the left who believed in equal rights and human rights. But they said, sometimes I have to tell my patients, to an adolescent patient, you really have to take your medications, or an elderly patient. I can't be kind of us and them. There has to be a hierarchy. At the same time, they challenged it in various ways. And a lot of these doctors talked about the sort of placebo effect that a physician can have. So a number of physicians said things like the following. When I was sick at one point, I was so upset not knowing what was going to happen. And my doctor put her hand on me and said, everything will be okay. And I felt so much better. I just felt so relieved, just that physical touch. And I never realized that. And I've been a practicing physician for 30 years, and I never realized how effective that touch can be until I became a patient. And in a way, one could say it's sort of a placebo effect. I just felt good from what is a non-medical intervention, and yet they now did not know that they had this effect on their patients. And again, I think it speaks to the way in which healers are more than just a body of science, but really we are healers in a more spiritual, non-scientific sense. And after doing this, I went to Greece 2 years ago, and I went to Epidaurus, which was a center of Hippocratic healing cults in ancient Greece. And there in the compound, there were three things. There was the theater, which Epidaurus is most known for. It's a huge theater that seats 2,000–3,000 people from 500 BC. There was the temple, and then there was the healing area, right? Sort of the hospital. And there were all these stela, these large marble slabs they found with cases described, right, of sort of what we did and how what happened if a woman comes in with stomach problems or pain, et cetera, et cetera. And I realized there in one compound, patients would go, and there was healing, there was sort of the medical center, there was the temple, there was a spiritual element, and then there was the entertainment, right? There was theater. There was something more. There were the humanities, I guess you can say, right? And so these were combined in a way, and I think we've lost that. I think American medicine has sort of shifted, going to sideline here, but became, starting in the late 19th century, more scientific, and we've lost some of the spiritual stuff. And I think that these physicians spoke to it, to that very eloquently. When they became patients themselves, it's not until they became patients themselves, though, they realized the importance of these other issues. Similarly, though, they often had to decide, again, how close or far to be, how much to have a hierarchy or not, and how to do that. And they realized they had to negotiate that with each patient to see what the patient wanted, how involved to be. Some, and this has been written about by others as well, but some said, I'm not going to tell my patients what to do anymore. I'm going to leave it up to them. Here are your options. You decide. And then they'd come back and say, Doc, don't you know what to do? And so the notion of sort of there being a balance between sort of detached concern. You want to be concerned and detached, but not too detached or too concerned. That became difficult. Some of these doctors said, after I became a patient, I began to give my cell phone number out to my patients. I became really interested in taking care of them. I felt so uncared for by the medical system. I said, I'm going to not do that. I'm going to give patients my cell phone number, call me anytime you want. And then they began to call me anytime. And that wasn't right either. I needed some distance. But they tried to renegotiate that in different ways and often approach that differently than they had before. Similarly with adherence, so they would say things like, I used to tell my patients, look, you need to take this medication, you need to take it all the time. And then my doctor gave me medication to take, and I realized I'm not taking it all the time, right? I miss doses, or with diets. I would tell my patients, you have to be on a low-salt diet, you have to be on a fat-free diet. And I would tell my patients this, and then I'd go to Burger King on the way home. Right? And I realized, I don't practice what I preach. And what does that mean? That here I'm busy preaching this and practicing that, right? Sounds like a lot of people who preach sometimes, or some people who preach. But, and so they began to sort of change the way they approach that with their patients. They began to say things like, instead of, why aren't you taking your medication? They would tell me, I now say to patients, well, it's great you're able to take your medication 80% of the time. How can we work together to get up to 100%? Things like that. And a lot of these doctors talked about picking doctors, and some said, I ask, and I'm still intrigued by this, they would say, whenever I need a physician, I ask my friend, colleague, barber, whatever, I say, who's a good, GI doc, who's a good whatever it is, because she has good taste in choosing doctors. So what is that, good taste in choosing doctors? But I think it speaks to something, right? That I think there is a certain amount of almost aesthetic taste, or it is something beyond an outcome measure per se, in terms of good judgment, integrity, and things like that. And a lot of these doctors said they would suddenly, as a patient, they would go to see colleagues whose reputation was not borne out to them when they themselves were a patient. So they would say, and had to go see endocrinologist, whatever kind of specialist, oncologist, and I always thought so-and-so was a great, whatever it is, great oncologist, right? Great reputation, publishes all the time, NIH grants. And I'd go to see the person, and I was stunned. They were brusque with me, they didn't really care. And how we really don't know how to assess someone's reputation. That, it's one thing for a patient to see. The experience of being a patient, judging a colleague, was completely different than the experience being a colleague judging a colleague. And yet we rely on our reputations in all kinds of ways. I think that has implications for us. And these doctors had tensions also between, in picking doctors for themselves. They could be treated in the hospital where they work, or the medical center where they work, in which case they would be a VIP, but they would lose privacy. So they would say, one was a number of the people were trainees, but one was a resident on the ward, and who said, my attendings would come by and say, oh, it looks like you're ready to go home in a few days. Whereas my attendings were busy reading my chart, right? Which to me felt like this violation, even with HIP and everything else. There's this odd, when a doctor becomes a patient, there are odd boundary questions that get raised that are very hard to maintain. And this attending is used to looking up lots of patients' medical records, right? And so he would round on his floor, and then he'd go up and visit his resident and see how the resident was doing. And similarly with, in terms of coping, a lot of these doctors had difficulty giving up the doctor role. So they would say, they would ask me, is it okay if a doctor cries? And I'd say, well, what do you mean? I said, well, sometimes I get treated here, and I come back, and after seeing my doctor, and I just want to cry, and I feel I can't. I'm a doctor. I can't cry. And I think that speaks to something, and how we have to be. A lot of these doctors talked about that they're workaholics, or doctor. They would say, I had difficult upbringing, or whatever it was, and my dad was an alcoholic or whatever, and being a doctor gave me a lot. It really did something for my self-esteem. I'm Dr. So-and-so, right? And we don't think about this in what we do every day, but of course it enters in many of our lives. Our past affects us, and they said, they didn't want to give up this role of the doctor, and to be a workaholic, they would say, this way I don't have to have a social life. If I don't want to go out with my kids, I can say, well, I have to go see my patients. I have patients to take care of. And then they said, now having been a patient, I realized, I need much more time for my kids. They really began to reprioritize. Some said, I tried to work part-time, for instance, and remember these doctors said, after I got sick, I said, I'm going to take it easy now. I'm only going to work so many hours a week. I'm going to work less. And it didn't work. Because somehow, I don't know why, but I'd go back to the office, and the next, a month later, I'm busy working, umpteen hours a week again, even though I tried to cut back. And I don't know what that's all about, but I think it's worth our thinking about in serious ways as providers. And in retiring was very hard for a number of reasons. Some would talk about, what am I versus what I do. So at first, some of these doctors started to say things like, when I retired, when I make a reservation at the restaurant now, do I say it's Dr. Smith or just Joe Smith? Right? When I meet neighbors and there's a local community block party, blah, 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 do I say Dr. Smith or do I say Joe Smith? And at first I thought, this is all minor stuff, but they kept bringing it up, these doctors, and I think it really spoke to something about who you are versus what you do. At the same time, there was a lot of stigma they felt, often, and discrimination. So one woman I interviewed was a resident who had metastatic breast cancer, and at first she was doing better. She really wanted to go back to work. She went back to work, and she found they took away her voicemail. And there's a list of everyone's voicemail. They took her number away. They took away her patients. And no one can deal with her being back at work because they felt she was only going to be here for a limited amount of time. And she meant a lot to her. She realized she may have a year or so or however much time, and she wanted to do this. But fellow physicians often had a hard time dealing with, of course, a colleague who is ill. And people wouldn't, if someone had been ill, even if it wasn't metastatic, other providers would often not refer to that patient. And a lot of these patients didn't know when they should retire, how much they should work. Often it wasn't until they felt they were sicker than their own patients that they felt it was time to retire. A few would say, I'm suddenly sitting there and my patient's complaining about, Johnny failing in school and what's going to happen. I'm Johnny, and I realized, they felt like saying, they would tell me, I feel like saying, lady, I have worse problems than you do. And it's at that point that they decide, I really shouldn't be practicing anymore. But it was often hard to come to that point of knowing when one should retire. Many felt peripheralized, that even if you just had an illness and didn't want to retire, on the other hand, not only would people refer less to you, they wouldn't ask you to be involved in grants, they wouldn't ask you to, colleagues wouldn't ask you to help write papers, etc. And there are a lot of issues around that, around our peripheralizing our colleagues. And so another set of issues, I'll talk for a few more minutes and then stop just for questions and answers. There were questions, what can other people learn from my experiences? And I mentioned some things, often around giving bad news and how it's, in some ways people would say, she has a real talent for giving bad news, and I try to copy that. Or a few patients would pick up little things their doctors would do for them or with them. So these doctors said, when I was in the hospital, I had 5 or 6 doctors would come in treating me for this or that or this. One doctor would come in and instead of standing at the foot of the bed would sit down by my pillow and talk to me, and that made all the difference. And now I tell all my trainees that's what they should do. Another said, one doctor would come by and fill out the chart notes at the bedside rather than going back to the nursing station. And that made all the difference. And I now tell trainees to do as much paperwork, et cetera, there in the room, even if you're just not really interacting with the patient much. Occasionally there's a few sentences of interchange. And they said, should, questions come up, should all doctors or trainees be patients? Obviously it's not very practical. But I think that these insights can help in different ways. At the same time, these doctors struggled with, can you teach empathy, right? Can you teach what I've learned through this? I think there are things. They talked about specific skills. It was unclear if you can teach empathy or not, but there were certain skills. some of these doctors talked about, they said, you know, at times now I feel like I have to play act sympathy. I have to play act empathy. I'm not feeling empathetic. I've had a long day. I've been on call, but I have to play act it. I think there's something to that we don't talk about much, that they would have to, you know, act the part of the concerned doctor even when they're tired, exhausted, and don't feel like it. And many of us do that in many settings, and yet, I don't know, I mean, I half facetiously wonder if we should have an acting class in medical school. You know, how do you play act being the good doctor when sometimes you don't feel like it? And I think that's an aspect of what we do that we may want to give more attention to. And similarly, getting things in language explained, they're much more careful about explaining time, etc. I can talk more, but I thought we have some time left for questions, and I thought that rather than me babbling on, and I should say there's much more material on all this in the book, if you're interested, in many other ways in which these doctors learn from their patients. But I thought I'd stop there and open the floor up. And I think these doctors, I'm very grateful to them because they shared their experiences with me. And I think their hope was that even if other medical trainees and physicians can't be patients themselves, that they can learn from the experiences of these doctors who did become patients and were able to share their experiences with all of us. So on that note, I'll stop, and I'll be happy to answer any questions. And again, thank you very much.
We have time for questions. Yes, Lori?
Well, I was thinking of an excellent talk, and I find all the information you presented very pertinent to what I do in palliative care, especially. And the very last few sentences you said about empathy, and can you teach empathy, I think are so key, because I think I see a lot of physicians who acknowledge, yes, it's so important that I spend time with my patient. It's so important that I respect them and that I restore their dignity if I can while they're in the hospital, for example. But I think that there's some sort of disconnect between what we're taught, what we think we know is right and what to do, and what we actually practice. And I don't know if you came up with any insight into how do we, other than sharing stories from physicians who've been patients, maybe that it has more meaning for us, you know. But how do we get from point A to point B?
Right. So that was a great question. And could everyone hear the question? I should repeat the question. The question is, there are a few interesting, important comments you made. You work in palliative care, and there's a question, how do you teach empathy? And how do you, people may realize they need to be empathetic, but how do you get there? There are a lot of obstacles to becoming empathetic. A lot of the jury was out. Can you teach empathy or not? But there are definitely skills. So for instance, a lot of these doctors said things like, the doctor would come in and see me and leave. And I had questions and were never asked. So now, they tell me, I make a point, I train myself with every patient to say at the end of the session, are there any questions that you have? Do you have any questions? And even when I'm thinking about the next thing and I have 5 emails to respond to and 3 calls, I'll stop. And occasionally I'll start to walk out the door and I forget that. And I force myself to come in and say, do you have any questions? So I think there are little things like that that are skills. I think to sit down, not to stand up, not to stand in the, there and wave hello. To say, I'm sorry to have kept you waiting, acknowledges a great deal, right, when people are waiting. And that takes how many seconds, right? 2 seconds, right? But it can actually have meaning. And, unfortunately, it would be great if we lived in a healthcare setting in which there weren't time constraints and people could sit down and really get to know their patients. Well, that's realistically not going to happen for most of us anytime soon. But I think there are these other things. I think saying rather than you need to do this, right, the sort of around the adherence issue, saying, as these doctors said, rather than, why didn't you take your medication all the time, saying, well, it's great you're able to take it 80% of the time, how can we work together to get it up? And to realize how important these issues are, I think also. So, if you are rushing in and out, there is a cost to that. And I think that the power I try to convey in the book, especially the power of these doctors' voices, because patients complain, we all hear patients complain, and we dismiss it. sort of structurally, that's just the patient complaining. Right, where again and again these doctors said, patients complain, and I used to dismiss it. But as a doctor, this is a fellow doctor complaining, saying to other doctors, this is something we just don't do right, and we need to do better. So I think that there are ways, I think stories and narrative can help, and I think that, hopefully we can incorporate this into our teaching. Yes? What's that?
Sounds like communication classes, and you're right on the ask.
Well, I think so. Even sort of the anecdote of 5%, 95%. I mean, I was stunned that this doctor would say to me, I've been a surgeon for 5 years and never knew there was a difference between those two. And this was a nice surgeon. This was like a nice guy. You'd think he wasn't like a mean, nasty whatever who would say this. So even, that's why I came back to the William Hurt thing earlier. The Hollywood version, horrible person becomes better doctors. But these were good doctors to start. These are people you'd feel comfortable sending a relative to. And they said, even I found things I really didn't realize before.
Question about the dimension of patient experience as relates to aesthetics. Did you notice or object to aesthetic environment in front of yourself, such as food?
Yes. Yes, so I mentioned with the crack in the window, that they said, and there were no fresh flowers, but the physical plant, and the food was terrible, et cetera. And in the way in which, patients complain about food, completely off the radar, right, for doctors around you generally, was these patients were said, really how horrible, it just sort of, I think, embodies something about the loss of dignity. And of course the loss of dignity is important because it suggests a loss of life, potential threat of mortality. And again, I think there's something about your life being threatened that forces you to really examine in a fundamental way your values and how you look at these things. But yes, I think these aesthetic things were crucial, I think, because of what they represented. Of course, aesthetics usually represent something else, right? I mean, if you go, the picture of religious art represents, it's not just a picture of whomever, a prophet or a saint, but it's what they stand for. And I think that what the bad food and the cracked windows and the dirt in the corner or the broken phone or the broken TV or whatever it is stands for some of this as well. So yes, aesthetics, I think, were powerfully potent. And again, we're an example of what was they did not appreciate before and now did. Oh, yes, sorry.
Actually, I wanted to, on that note, to kind of get back to something you mentioned earlier about how do we measure these immeasurables? How do you say, did we do a good job of respecting your human dignity during the hospital stay? Did you have any experience with progressions?
Right, great questions. The question was, how do we measure the immeasurables? And is there some way of capturing how was your loss of dignity during your hospital stay? Is that capturing, right? It's a great question. I think it speaks to a few things. One, wouldn't it be nice if there were an easy way to do that? I think to realize that any scale we come up with is going to be problematic, which doesn't mean don't come up with the scales, but understand that it's only part of the picture, right? So if we do come up with, I'm reminded of, there's a colleague I work with who, a few years ago, she was doing a project and I recommended her including a patient satisfaction scale. And she said, well, I don't want to use that because I remember I read one patient satisfaction scale and they asked patients about what offices they like going to the most. And the main factor was, how is the parking? That it turns out that in this one study, if there was good parking, the answer was yes, I like going to that doctor's office. If there wasn't good parking, I don't. Well, of course, you can say, well, it shows a few things there, right? So they asked not how is it going to that seeing that doctor, what is it like going to the doctor's office, right? So even that little subtle switch of words, things like the parking become important, right? So I think to realize that there are these other domains that are hard to capture. I think it speaks to the art of medicine, which is still there, and we need to pay attention to that, and that a lot of metrics are not going to capture that, and it doesn't mean that this is important. It doesn't mean you shouldn't have the metrics, but to realize that there's a gap. I mean, you can try to capture it in some ways. I think it's a big challenge. And partly because people may not think in terms of dignity. They don't say, my dignity was violated. They'll say, the thing that bothered me most was I had this beautiful wavy blonde hair and I lost it. And that I would I would get up in the morning and there on the pillow would be the hair, and she'd start to cry as she tells me this. Right, so that says, and stuff like that I never paid attention to before. And I think it speaks for itself. Yes? Oh, I was thinking well, go ahead, yes, that's fine.
That was a nice segue into my question. Do you see a gap between genders? A male doctor with a female patient, particularly in situations in which gender is relevant.
Right.
A female doctor with a male patient.
Right.
Whether it's impotent, mastectomy,
right.
infertility, pregnancy, whatever.
Right. It's a good question. Were there gender differences one way or the other? And interestingly, there were no clear gender differences. And I should add, a number of these doctors talked about bad experiences they had with women doctors. There was no clear gender distinction. So, some of these doctors would say, I went to, what's that?
That could be one right there.
Well, right. So
part of our society is that the woman is not in a superior position for men, and yet a female doctor would, in a sense, be in a superior position to a male patient.
Yes, so there's female doctor to male patient. There's also female to female. So a few of the women said, I had a woman doctor, and I had seen a male doctor, I thought he was mean or whatever, I didn't like him. I went to this woman, I thought she'd be better, and she was no better. She was busy and rough and blah, 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 blah. And that happened a couple of times. So people would say, here I thought that the woman would be better, and yet, I went to this woman surgeon, and she was as tough as the guys. Now, that says a few things, because on the one hand, I'm sure to be a female surgeon, you really need to be as tough as the guys, right? And of course, you could also argue whatever inherent extra empathy perhaps one can say women may have, there's a selection process and a winnowing out, and a who survives the top of the heap thing is not good. So it wasn't clear, because there were very nice. Some of these doctors said, I saw a woman wasn't very nice. I went to see a guy, and he was so much nicer and more empathetic. So some of these things I think cut across. It's complicated. So you can have, empathy can vary. You can have very empathetic men and not so empathetic men. You can have very empathetic women and not so empathetic women. So it's a complicated picture. Interestingly, most of these doctors said in the end I would choose someone who's a nice doctor. And what's interesting is, and I thought this, and I go into this more in the book, but one of these these doctors said to me, look, he said, in my medical school class of 150 people, we're all basically the same in terms of clinical skill. Maybe there was one guy who had a little better whatever, and one woman was more interested in research and really wasn't a good clinician, but everyone's about the same. And so in the end, the difference was going to be, we went to a good medical school, etc. It was going to be who was sort of a little more empathetic. And a lot of these doctors say, I would trade off. I would prefer, 30% more empathy for 10% less extra clinical skill above the norm, right? That's sort of what it came down to. I prefer, given that everyone is about the same, right, they're a well-trained doctor in a good medical community, I prefer the little extra empathy because it's important in all these ways. Yes?
Did you see any patterns of behavior of physicians and patients correlated with the physician's specialty?
Yes.
And is there anything you can tell us about what you've learned about the appellation to doctor's doctor? Who are the good doctors to their fellow physicians?
Right. So a few things. So it came out really, the question was, is there differences among specialties? And the doctor's doctor, the doctor's doctor meaning that doctors are bad patients, or?
In almost every hospital, there's one physician referred to as the doctor's doctor, who you go to for your medical care.
Right.
Listen to 75 people talk about their experiences with a patient. What did you learn if you want to be named the doctor's doctor? Right.
So do you want to be the doctor's doctor? So a few thoughts. And I'm sorry, the first part was the
behavior that results in specialty.
Right, it's a specialty, thank you, right. So in terms of self-doctoring, people tended to self-doctor more, it seemed, if they had a diagnosis that they were used to treating. So if it was a psychiatrist who had cancer, the psychiatrist would defer to the doctor. Or if it was a pediatrician who had an adult disease, he would or she would defer to the treating physician. But if it was, an internist with diabetes or an internist with, cancer, an internist with an internal medical problem, that person was much more likely to self-doctor. And a few things. So they would also, in other whole areas, they would take much more, their approach to risks and benefits. So some of these doctors would say things like, I was diagnosed with such and such, some rare leukemia or rare blood disorder. And I read there was a new treatment that had been tried on one patient on the West Coast. So I flew out to be the second patient. And I thought it's interesting. I said, would you ever recommend that for one of your patients? Oh, hell no. Well, why not? Well, because, I know I could evaluate the risks and benefits. I know what my patients couldn't do that. And I thought that was interesting. I think that speaks to a certain true aspect of what goes on out there. And of course, I would argue a patient may be able to evaluate the risks and benefits and want to do that, right? So some of these, now we're sort of verging on a little bit of self-doctoring being that aggressive, but I spoke also to the assumptions we make about what our patients want or don't want or can handle or not handle. The doctor's doctor. I didn't hear that as much, that there was a doctor's doctor. There was much more doctor. I actually interviewed a few doctors in this who said, I've treated lots of patients. And they would talk about different kinds of patients who were doctors. So, and they would talk about some of the phenomena. So one was, they would say, I've seen various doctors who are patients, and one main problem is, because they're self-doctoring and they're managing their own case, I don't know, am I their primary doctor? I've learned to set very clear boundaries with them, that if I'm going to treat you, I need to be your doctor, you need to listen to what I say, it has to be a real relationship. Because otherwise they go around and they're seeing this guy there for this, and they're getting a curbside consult for this, and they're getting curbside consults for them, or picking who they want. And also, what happens is that a lot of doctors see doctors and their colleagues don't give them feedback. So that's good feedback. So doctors don't, you'll say to someone who's a fellow doctor, so how's your treatment going? Well, I kind of stopped it or whatever. And no one's going to say, or no one's going to follow them and say, have you been getting your treatment? Or it's assumed if you're the doctor, you know what you're going to do. You know what to do. Another problem actually was patients' families. So because doctors have a certain role in their family, right? So once a doctor's sick, what came out is, a wife can't, if a wife says, honey, shouldn't you be taking your medication? Or shouldn't you be going to the doctor for that? The answer, of course, is, I'm the doctor. What do you mean, should I be going to the doctor? You're not a doctor. I know what I'm doing. Right? So whereas normally in a couple where one member is not a physician, the line, shouldn't you be going to see a doctor, honey, for that, will help get the patient to see a doctor. If the honey is a doctor, it's not going to work as well. So the term doctor's doctor came out, as I said, there were some I interviewed. It was very problematic because of these boundary issues and not knowing, people sort of doctor shopping and curbside consults, etc. And there was a referral more to sort of the old days. A few doctors said, there used to be a guy who was sort of the doctor's doctor, or the, who was basically often a very humane, humanistic kind of guy, but it was a little more diffuse in contemporary insurance, and there no longer being courtesy care, for instance, I think has sort of diminished that in the way that it once might have been there. Other questions? We're out of time. Okay, well, I'm happy to talk afterwards. If you have a question, just come up.
I just wondered if all the interviews you found any physician who did not learn something from being a patient.
They all learned something, much to their surprise. Thank you all very much, and if you're interested, the book goes on more about it. Thank you.